Well, good morning to everyone. I'm Dr. Laura Lacher, and welcome to Medical Grand Rounds. I am here live in Southern Auditorium at Providence St. Vincent, so welcome to all of you, and welcome to those of you joining us virtually. We'll start with some reminders, some logistics, and then introductions for today. Next week, please be sure to join us for Grand Rounds. It is our annual Andy and Bev Hansel Lectureship in Medical Ethics, so please be sure to check that out. Grand Rounds, as many of you know, is now a joint effort between Providence St. Vincent and Providence Portland Medical Center. We are often live here in Southern Auditorium on Tuesday mornings at St. Vincent. And stay tuned for some live Grand Rounds Tuesdays at noon at Providence Portland. You can always join us virtually through Teams Live, and you can earn CME credit for being here in person, for watching live virtual, or for watching a recording of the event. And that recording is always available as the same link as the Grand Rounds invite. The Grand Rounds invite also always lets you know whether or not we will be meeting live. I'll be monitoring the Q&A throughout today's session, so please go ahead and post any comments or any questions for those of you joining us online. And now on to introductions. I am delighted to have with us today Dr. Sonam Kewalkar. She is a practicing rheumatologist with the Vancouver Clinic and also Associate Program Director for the Legacy Salmon Creek Internal Medicine Residency. Dr. Kewalkar earned her medical degree at Dr. D.Y. Patel Medical College in Pune, India, went on to complete her residency in internal medicine, as well as chief residency at Rochester General Hospital in Rochester, New York. And then fortunate for us, it came to Portland, Oregon for fellowship in rheumatology at OHSU. Dr. Kewalkar is currently completing a master's in education for health professionals at the Johns Hopkins University and is very active in medical education, certainly locally as well as regionally and nationally. She co-chairs the Oregon ACP's Committee for Residents and Fellows. She has received the Clinician Scholar Educator Award for her work in creating virtual patient modules for the American College of Rheumatology. In her spare time, hard to believe that there is a lot of that, Dr. Kewalkar, with all of your professional activity. She does love cooking and hiking regionally in the Pacific Northwest with her husband, and she's a mother. Thank you, Dr. Kewalkar.
Good morning, everyone. I hope you can hear me okay. Excellent. So thank you for the opportunity, Laura. Let's talk about approach to joint pain. No direct disclosures to the talk. And these are the learning objectives. The first learning objective is describe 3 types of pain mechanisms. Second, compare and contrast inflammatory and mechanical joint pain. Third, create an approach to joint pain using key features from history and physical exam. Fourth, apply these above frameworks to diagnose patients with common rheumatologic conditions presenting in the primary care clinic. Let's jump directly into framework 1. Let's talk about mechanisms of pain. After you get a history, including onset, duration, aggravating, relieving factors from the patient regarding their pain, you might be able to classify their pain into one of these buckets, and sometimes even more than one of these buckets. Bucket 1 is pain coming from the periphery, nociceptive pain. It's usually due to inflammation or mechanical damage from injury, trauma, or osteoarthritis, rheumatoid arthritis. It usually responds to NSAIDs, opioids, or procedures. The second bucket is neuropathic pain, tingling, numbing, burning sensation due to damage or entrapment of peripheral nerves. And the common examples are diabetic neuropathic pain, post-herpetic neuralgia, and carpal tunnel syndrome. Next, the third bucket is centralized, also called as nociplastic pain, where there are central disturbances in pain processing. And the poster child for this bucket of pain is fibromyalgia. And just as a clinical pearl, whenever you're assessing a patient with fibromyalgia, don't forget to inquire about symptoms of irritable bowel syndrome, tension, headache, and TMJ disorder, because they are all linked, come under the same bucket. So that is our framework 1. So after getting a history, try to apply this framework 1 and see where the patient could fall into, which buckets they could fall into. Next, if you do believe the pain is coming from the periphery and it is true joint pain, you can then divide this pain into 2 buckets again: inflammatory joint pain and mechanical joint pain. I feel mechanical joint pain is easier to understand because we just see it so often. So let's start with mechanical joint pain. Let's look at some of the characteristics of mechanical joint pain. So there is usually very minimal morning stiffness, defined as less than 30 minutes. Swelling is usually absent, but there could be some bony hypertrophy present. Inflammatory markers are normal. Pain is usually better with rest, and it worsens with activity. Let's contrast that to inflammatory joint pain, where you have a lot of morning stiffness. Swelling, doughy swelling is usually present. Inflammatory markers, either ESR or CRP or both, could be modestly elevated. It is usually better with movement and worse with prolonged rest. And that's why after a night where the patient is usually not moving a lot, their joints get stiffer and swollen in the morning. And as they start moving, the lymphatics actually suck out the extra synovial fluid, making their joints feel less stiff and better as they get moving. So that's the basic difference between inflammatory and mechanical joint pain. So that's your framework 2. We started with pain, just analyzing, getting a good grasp on the history. And next, what we did is we tried to put the pain into one of the 3 buckets. As I said, sometimes even all 3 buckets, right? And then if you really think the pain is coming from the joint, then you can further classify it into inflammatory or mechanical. Okay, so this is my favorite framework. This is framework 3. So joint pain. Just take a step back and think about the pain. Is it widespread or is it more localized and specific? If it is widespread, you might start thinking about perhaps fibromyalgia should be on your differentials at this time. If it is more localized and specific, let's use framework 2 to build on framework 3, right? So let's look at morning stiffness. Is the morning stiffness greater than 30 minutes? If not, the next question series is, does it worsen with movement and improve with rest? If the answer is yes, you're probably dealing with a mechanical joint pain, maybe osteoarthritis. It could also be related to trauma or some ligament or meniscus injury or even a rotator cuff. But just to give you an example, osteoarthritis. And I have put in some common joints affected by osteoarthritis in the blue box. Let's say if the morning stiffness is indeed greater than 30 minutes, and that brings you into the inflammatory bucket. The next question is it acute or is it insidious in onset and course? So if it is acute, don't forget, septic arthritis is a do not miss diagnosis. And then of course there is gout, there is pseudo gout. If it has more of a chronic or even a subacute course, you might think about, is it polyarticular and more upper extremity involvement? Think about rheumatoid arthritis. If it is mono or oligoarticular, think about peripheral spondyloarthritis, which include psoriatic arthritis, reactive arthritis, and inflammatory bowel disease associated arthritis. However, I would caution that this is not a watertight compartment, right? It pretty much could be overlapping, and we are going to look at these through some cases to give you some more nuanced information, but this is the basic structure. Let's look at common things. Okay, also remember the migratory joint pain. For those of us who are practicing more in the hospital, I think it's very fair to see disseminated gonococcal infection, post-streptococcal infection, infective endocarditis, especially the subacute infective endocarditis, presenting really kind of in not a very acute, but a little bit of subacute nature, and then they present to the hospital. So definitely don't forget all your infections when you're thinking about migratory arthritis, migratory polyarthritis. So with that information, let's go into case 1. The cases become a little more complex as we go from case 1 further. So let's embark on this journey together. And these cases are supposed to be interactive. So even the audience who are remote, as well the audience present in the room, feel free to shout out your answers if you know what's going on. And let's try it out. So case 1, we have a 42-year-old female with pain and swelling in hands and other joints. More than 3 months, this started more than 3 months ago. It is worse in the morning with more than 1 hour of stiffness, difficulty with doorknobs, making bed, no other symptoms or medical problems, no medications. Great. What's the physical exam? Physical exam shows bilateral swelling and tenderness of the second and the third PIPs and second and the third MCPs, and there is left wrist involvement and bilateral ankle involvement. So based on this, what is your diagnosis? Excellent, love it. Rheumatoid arthritis, very good. So going through our framework really, because there is joint swelling, you know it's coming from the periphery, and it is inflammatory because of morning stiffness, swelling is present, and it is worse with prolonged rest. And it was localized, and it was insidious in onset, it was additive, it was symmetric, polyarticular, right? So rheumatoid arthritis is higher on your differential over here. Okay, so great, you have diagnosed rheumatoid arthritis, but the main question is, what do you do next? Because the wait to rheumatology is 6 months. Okay, so what is the next step? What is the next step? Okay, so let's get a CBC, a creatinine, a liver function test. Let's get both ESR and CRP, because sometimes just one of them might be present, and very modestly so. So we are trying to gather each piece of information we can. Please get a rheumatoid factor and anti-CCP. Again, get both. These are used, the RF and CCP are not only important for diagnosis, seropositive versus seronegative, but they're very important prognostically. Seropositive patients, seropositive RA patients have more extra articular manifestations, especially ILD, and they could have a worse prognosis. The best thing that you could do, click a picture, upload it to your EMR, so the rheumatologist seeing the patient knows what the hands or the extremities look like before you started them on treatment. Okay, so treatment is NSAIDs. If the patient's chemistry panel is fine and you feel confident starting NSAIDs, that would be a good choice. I usually do a 500 milligram twice a day naproxen for a few weeks, or meloxicam 15 milligrams at night with food, which usually helps people. But sometimes you need oral prednisone, and that's fine. So usually for joints, you don't really need to go higher than 30. So why don't we just keep the figure 20 in our mind? So 20 milligram, 15, 10, 5, let's say 3 to 5 days at each level. That would be a pretty good dose if somebody's presenting in a RA flare. And then, of course, that's just a bridge, right? It's a bridge to DMARDs. And in the primary care setting, I think starting oral methotrexate plus folic acid is a good way to begin the DMARD treatment. And of course, we have UpToDate and we are going to look at the dosing when the time comes. But these are just a few tips that could help you confidently start methotrexate. So before we think about methotrexate, very important, please prescribe folic acid 1 milligram, which is 1000 microgram a day, prescription, because the one that you get over the counter is only 800 microgram, and sometimes the other brands are only 400 or 500 microgram, and people actually need the whole 1 milligram. Next, methotrexate, start low, start with just 6 pills once a week, give the prescription for a month, get their blood tests every month for the next 3 months, monitoring their if there are any cytopenias, any transaminitis. So that's what you're going to monitor when you're looking at the CBC and CMP. Ask the patient to limit alcohol to not more than 1 drink a week. If there is reduced or low EGFR, reduce your methotrexate dose. Maybe start at a 5 and just keep it at 6. Don't increase the tablets to 8 or 10. And these are the common side effects that could be seen with methotrexate, especially the fatigue. If there is a patient with fatigue after taking methotrexate, think about splitting the dose, half the dose in the morning, half the dose in the evening on the same day, and that could help, right? Simple things. Or what you could do if there is some GI problems like oral ulcers, you might think switching to sub-Q methotrexate. Okay, and that's it. I promise. That's it. Nothing else. Okay, nothing else. Okay, so let's take a step back from treatments and look at some clinical pearls. Rheumatoid arthritis spares the distal interphalangeal joints. It spares the spine except the C1 and C2. Again, an important pearl, especially for a long-standing seropositive rheumatoid arthritis patient who is severely ill, who is in the unit. Make sure you stabilize their C-spine before intubation. Okay, that brings us to case 2. We have a 66-year-old man. He's worried he has rheumatoid arthritis because his mother has rheumatoid arthritis. He has years of pain and enlargement of his hands and knees. There is morning stiffness about 10 to 20 minutes. There is difficulty holding objects. There is pain with excessive use. Physical exam. Firm swelling of DIPs and PIPs. There is the CMC tenderness, base of the thumb tenderness. And knees are tender to palpate, and there is some enlargement of the knees you see, and there is some crepitus when you do the range of motion for the knees. What is the diagnosis? OA, perfect, osteoarthritis. And then again, just running through our frameworks, peripheral, mechanical, and morning stiffness less than 30 minutes, and involvement of typical joints, right? You saw the hand with the CMC and the DIP and the PIP involved, and the knees. So pretty classic for primary osteoarthritis. Okay, so what is the next step? It's a clinical diagnosis. You really don't need x-rays, right? And conservative management. The American College of Rheumatology in 2020, I think, yes, 2020, has a guideline on management of osteoarthritis, which includes hand, knee, and hip. And this is the quick summary of conservative management, topical and oral NSAIDs, physical therapy, you can do CMC injections, and of course, if need be, surgery. Time for some clinical pearls. I would like you to concentrate on the photograph and look at the DIPs and look at the PIPs, right? So you see hypertrophy, you see bony enlargement, and if you actually touch those joints, there will be this bony, hard deformity, right? That's what you're going to see. You won't see that soft and doughy appearance that you could see and feel in a patient with inflammatory arthritis like rheumatoid arthritis. And plus it is involving the DIP, right? And also remember, primary osteoarthritis rarely involves the wrist, the MCPs, and the ankles. For some reason that we really don't know, that's where primary osteoarthritis usually spares those areas. Remember, I'm talking about primary osteoarthritis over here. Okay. Now, the plot is going to get a little thicker. So, 50-year-old female, 6-month history of joint pain and swelling, 1 hour of morning stiffness, physical exam. The right first, second, and third fingers are swollen. The left first and second fingers are swollen. The right knee has an effusion. The right second and fourth toes on the right and first and third toes on the left are swollen. What is your diagnosis? And feel free to just brainstorm ideas, right? We can create a differential. We don't need a final diagnosis. You are a smart bunch. Yeah, so absolutely psoriatic arthritis. It also could be rheumatoid arthritis, right? We still need some more information. Absolutely. And then on physical exam, you do find these 2 hidden silvery plaques in the umbilicus and something hiding in the scalp, and then you're more confident about your diagnosis. Again, it's coming from the periphery. We know that. It's inflammatory, right? And again, just to show you, even though we spoke about psoriatic arthritis being more lower extremity asymmetric mono or oligoarticular presentation, it can 100% mimic rheumatoid arthritis, especially when you don't see those psoriatic plaques. And I will give you some pearls about how to find them later on. But do remember, again, this is not watertight compartments. Psoriatic arthritis can absolutely mimic rheumatoid arthritis. Okay, so we have established that this is psoriatic arthritis. This is what we feel. What is the next step? Similarly, start with basic labs, right? Get an ESR, get a CRP. So you may consider, let's say if you really don't find those small plaques, and even if you do find those small plaques, I think for completion's sake, I don't see any issue getting rheumatoid factor and a CCP as a first line. And good news, rheumatoid arthritis and psoriatic arthritis, the first line of treatment is methotrexate and folic acid. So we just have to remember one drug in rheumatology. And remember, it is teratogenic, right? Remember, it's teratogenic. Okay. Let's go to clinical pearls. Let's not forget to examine the umbilicus, the gluteal cleft, and the scalp, and especially the back of the ears. Psoriasis loves to hide over there, loves these places. And remember, dactylitis, the diffuse swelling of the digits, that was dactylitis, right? Dactylitis is a feature of psoriatic arthritis. Okay, so some pictures, some images for you. And on the left side of the screen, you see the B panel. Look at the DIP involvement, right? So we now understand rheumatoid arthritis does not affect the DIPs, but osteoarthritis and psoriatic arthritis does, right? So that's your DIP involvement. And you see this asymmetric PIP joint, which is swollen, right? So that's to show your asymmetry as well as the DIP involvement. Next, let's look at panel D, and you see these telescoping joints. What it means is psoriatic arthritis is pretty destructive if left untreated, and it can really destroy not only the joint, the tendons, the ligaments, and the bone. It causes osteolysis, and then you have the extra skin just hanging out there, and that is your telescope joints or telescope digits. A very nice article written in the NEJM a few years ago. And actually, I worked with Dr. Richland in Rochester, New York, which was fun. So coming to clinical features of psoriatic arthritis, so you see this panel G, you see this joint right over here seems swollen than its counterpart. And then this is the heel. This is the heel enthesitis. This is just to drive home the point that unlike rheumatoid arthritis, which is more the synovium inflammation, the seat of inflammation in psoriatic arthritis is actually the enthesis. That is where the tendon or the ligament inserts on the bone. Okay, so in psoriatic arthritis, you can get synovitis, dactylitis, enthesitis, as well as sacroiliac joint involvement, right? So even though we think about rheumatoid and psoriatic arthritis on the same spectrum, there are these differences. Okay. Ready for a few more cases? Let's keep moving. Case 4. A 34-year-old female is worried she has lupus. Sorry, a 37-year-old female is worried she has lupus. She's new to your practice, 2 months of joint pain with 1 to 2 hours morning stiffness, fatigue, poor sleep, difficulty focusing, hair loss. She has this new facial rash after the sun exposure. She has diffuse tenderness of multiple small joints of her hands. Prior labs done a few months ago show a normal CBC, CMP, TSH, UA, except hemoglobin being 11 at that point. Her ANA done a year ago was 1:160, a homogeneous pattern. What is your diagnosis? Absolutely. And what should you do next? So before going that, let's just quickly go through the framework. So the joint, concentrating on the joint pain, it is coming from the periphery. You see tender inflamed joints. There is morning stiffness. There is some swelling. And if you go that route, it is symmetric. The joint pain, if you just focus on the joint pain, yes, it is symmetric. But she has so many other extra articular manifestations. How do we fit that into framework 3? We can't. So we have the last framework, framework 4. So framework 4 really talks about accompanying features, right? So you have this inflammatory arthritis, and what else is going on? What do you get from your review of systems? And your review of systems for lupus really start head to toe, right? So you could have either patchy or diffuse scarring or non-scarring alopecia. You could have scleritis. You could have the malar rash, which spares the nasolabial fold. You can have oronasal ulcers, mucocutaneous ulcers, pleuritis, pericarditis, nephritis, DVT-PE, right? That's the most common spectrum of lupus. So it's very important when you're assessing a patient for inflammatory arthritis, make sure that this is indeed rheumatoid arthritis and not one of the mixed connective tissue diseases, and your review of systems will be very helpful when you do that. Okay, so what do we do? Next step, get a comprehensive workup, right? Get a CBC, CMP, ESR, CRP, get a urine microscopy, and a spot urine protein creatinine ratio. Okay, that will help you. And remember, even if the creatinine is normal, still get a UA. You might miss silent nephritis, right? Brewing nephritis. Spin the urine. Dysmorphic RBCs, you can see dysmorphic RBCs, you can see the protein through the roof, suspect glomerulonephritis and get the appropriate specialists involved. And of course, you're going to send an ANA, a full profile in this patient. Even though she just had that ANA, we want to get more information. What specific labs does she have? So the labs are back. We see a CBC of 3, hemoglobin lower than before, platelets lower than before. CMP creatinine is 0.9, but see, she was a 37-year-old female, and maybe something normal for her is 0.5 or 0.6, right? You never know. UA, it shows protein and RBC casts and spot protein creatinine ratio. Oh dear. And C4 is low. That's the complement protein. Low complements means active lupus, along with the anti-Smith antibody, which suggests lupus. And what is the next step? It really depends if it is a Monday or a Tuesday versus a Friday. If you can really get hold of rheumatology and nephrology, or send them to ER. I mean, no wrong answer over here, right? Glucocorticoids, should it be IV? Should it be PO? And then, of course, you're going to counsel them about sun protection and vitamin D, but that could take a backseat right now. And then oral hydroxychloroquine, right? So that's also good medication that I want to take a little detour and talk about it, because if you feel a little anxious starting methotrexate for your rheumatoid arthritis patients, or if your patient is concerned about their lifestyle and alcohol, or they want to get pregnant in the next year, right? So then methotrexate might not be the best option, and the safe option would be hydroxychloroquine. Okay, so let me just give you a few pointers regarding hydroxychloroquine before we move further. Okay, so hydroxychloroquine, it should be a weight-based dose. Do not exceed more than 400 milligram a day. That's the ceiling dose. Please recommend your patient to do annual retinal toxicity screening, and it is safe in pregnancy. Only 3 points as opposed to 10 points for methotrexate. It's a milder medication, so I think it's great for people who have mild to moderate RA. Lupus, it's like a vitamin. Everybody should be on that drug. So knowing methotrexate, but even knowing hydroxychloroquine will help you in your primary care practice. Okay. Coming back to the rash we saw, right? Lupus has a photosensitive rash. It spares the nasolabial fold. The things that I picked up during my fellowship, which I thought I wish I knew as a primary care provider, were that rash of lupus is really painful and burning and not itchy. It lasts for weeks. It's not like your typical sunburn. It comes on, it's itchy, it goes away in a few days. No, that's not a lupus rash. It stays on longer, it's burning, it's not itchy, and it spares the nasolabial fold. So I hope this will be powerful information to you when you're talking about photosensitive rash with your patient who's very concerned about lupus. And if you forget everything what I just said, if you just remember a negative ANA practically rules out lupus, I'll be very happy. So definitely keep that in mind. ANA has a very high sensitivity for lupus. It's 99.5%, and that means it can practically rule out lupus when negative. The problem is what to do if it is positive. And I have not figured it out yet. I don't know who has. Okay. So talking about some more frameworks, right? So let's take a step back. So we have inflammatory arthritis. We have established it as inflammatory arthritis, but we get a sense that it is more than only rheumatoid arthritis. It is affecting some other connective tissue areas. So how about dermatomyositis, right? So assess for proximal muscle weakness and look at this V-neck sign, the heliotrope rash, and the Gautron papules. So one of the things that drew me to rheumatology was I really am not, it's not getting an ownership of just one organ. It's actually the whole patient that you really have to assess via history and physical examination and really come to that diagnosis, which excites me. How about systemic sclerosis or scleroderma? Absolutely. It can just start as morning stiffness and swollen joints, and if they have predominant Raynaud's phenomena, think about systemic sclerosis or scleroderma. And this is the initial phase of systemic sclerosis or scleroderma. And later on, of course, you're going to get that sclerodactyly, and you could get Raynaud's with that digital ulceration. Dry eyes, dry mouth, swollen glands. Think Sjogren's along with your inflammatory arthritis. Okay. So next week, you see her twin. The same patient, case 4. Her twin comes because she's now concerned that she has lupus. She is also new to your practice. Since 1 year, she's noticing multiple joint and muscle pain that lasts for 1 to 2 hours in the morning. As you listen further, she also has fatigue, poor sleep, difficulty focusing, headaches, brain fog, hair loss, just like her sister. She has a facial rash too, which is worsened with sun and alcohol. Physical examination, multiple soft tissue tender points. Prior labs seem to be normal except hemoglobin of 11.8. Her ANA is positive, 1:80, a homogeneous pattern. So slightly lower than her sister, but in the same range. What is your diagnosis? And what is the rash? Can it be combined with? Excellent, excellent. Okay. So the pain is widespread, right? Patient has headaches, IBS. So you start thinking about nociplastic pain. What are the next steps? Because of the morning stiffness of 1 to 2 hours and because of the patient's concern, I think listening to the patient really helps. Reassuring them that you're going to do a thorough history and physical exam, and then we should discuss the next steps, usually is a powerful way to approach, rather than just doing a brief history and physical, and the patient shouldn't be felt dismissed. You really need to sit down, make good eye contact, and talk to the patient. I think these are the most important things that will help your patients in whom you suspect fibromyalgia. Another cool tool that you could use is the American College of Rheumatology in 2011 created preliminary diagnostic criteria for fibromyalgia. The QR code is right there. And it is a self-based tool. So it's a a self-administered tool. So really, you give this printout to your patient with a pen or a pencil and ask them to check box those areas that hurt. And that's to the left side of the screen, the widespread pain index, and then ask them to quantify their fatigue, their brain fog, their waking up tired, their abdominal pain, depression, and headache, and then you give them a score. So the score, anything more than 13 out of 31 points, if you have ruled out the other possible differentials, then fibromyalgia is highly likely. The higher you score, the higher the possibility that this is indeed the diagnosis. This tool has been pretty powerful, and patients really embrace the diagnosis much better rather than just me walking in and saying, you have fibromyalgia. This is a process, it takes less than 5 minutes, and it really helps patients because we unfortunately don't have any blood tests for fibromyalgia. Remember, patients with fibromyalgia also have prolonged morning stiffness, and that really doesn't help you differentiate inflammatory arthritis from fibromyalgia. 10 to 15% of the general population have a low titer ANA positive, and that's not going to help you either, right? And it could just be positive and they would never end up having a rheumatic condition, right? And especially in this patient whose twin has lupus, so there is autoimmunity in the family. So just by that, the patient might have a positive ANA and you really can't do much about it. Whether she would develop something in the future, she might, absolutely. And I always counsel my patients to see me back if symptoms progress or new symptoms develop in patients who have fibromyalgia. And rosacea, right? So nasolabial folds are included in rosacea along with the chin and the forehead. It is worsened by sun and alcohol. It has a papular, pustular quality to it and telangiectasias. Okay. And this is the 6th and the last case, and we'll have enough time for questions. 32-year-old male with pain and swelling of the left knee and ankle started 4 days ago. He's miserable. He's unable to work. Okay. I shouldn't have pressed that button. Okay. At this time, what are the differential diagnoses? Excellent. So crystalline arthritis, excellent. So it could be gout or pseudogout. Great. What else? Love it. Gonococcal. Anything else? Trauma. Sure. Yeah, it's the same left side. Sure. What else? Sorry? Reactive arthritis. I heard sarcoid. I heard reactive arthritis. Fair game. I think that's a great differential diagnosis. Love it. Some more history. Now revealing. Okay. 2 weeks prior, burning with urination, purulent discharge. 3 years ago, history of chlamydia. He's sexually active with 3 female partners in the last 6 months. Okay. Does your differential diagnosis, the priority change? What is our top differential diagnosis now? It might have been gout. What is it now? Or is it still gout? If we have anything on the chat. Yeah, absolutely. So we are thinking septic arthritis, which is absolutely possible. Okay. To make it a little more complex, 15 years ago, left knee dislocation due to a sports injury, and he has had intermittent left knee joint pain, but not this, where he has this swelling of the knee and definitely has had no problems with his ankles. Okay. Review of systems, negative for rashes, oral lesions, fevers, eye inflammation, back pain, and no recent travels. Okay. So what is your diagnosis? What are you still thinking? I want you to continue to move those differential diagnoses in your mind. Let's move on. On physical examination, the left knee and ankle, yes, are swollen, tender, warm, and painful, active, and passive range of motion both. Okay, so next steps. You see a large swollen joint, juicy joint, you aspirate it, right? You have to aspirate it. So you send for a CBC, WBC comes back 10.9, BMP is normal, a CRP 70, arthrocentesis, WBC count 29,000 with 85% neutrophils, no crystals, negative gram stain. Cultures are, of course, pending. What should we do? I love it. Yes, let's just pan culture him, right? Get some more. So at this time, as we are culturing him and trying to get more data, I think because of his high risk, treatment of gonococcal arthritis should be on the top of your mind, because you cannot miss septic arthritis, especially gonococcal septic arthritis, right? And of course, let's get the NAT urine test, throat, anal, vaginal cultures, HIV, RPR, negative, all are negative, except the urine chlamydia test comes back positive. So now what are we thinking? Reactive arthritis, perfect. So this is reactive arthritis from chlamydia. And then what we do is switch to doxycycline and treat the arthritis symptomatically. So you can either use, there are just 2 joints involved, you can actually inject both those joints, because remember, in reactive arthritis, the joint itself is sterile. Okay. Clinical purpose. Differential diagnosis for that spectrum. Again, see how those lines blur, even though I gave you a framework and I'm saying use it with caution. So, acute mono or oligoarthritis includes septic arthritis, crystalline arthritis, reactive arthritis, and LORA, that is late onset rheumatoid arthritis. I very recently had a patient who did not have any risk factors for septic arthritis, no gram stain, cultures came back negative, no recent infections, no sexually transmitted diseases. He was 70, I believe, and WBC count in the synovium was high, and that's why late onset rheumatoid arthritis could present in this explosive fashion, right? High ESR CRPs, more of an acute onset. So do remember late onset rheumatoid arthritis as a differential, especially in people over the age of 60 or 65. Let's talk about the synovial fluid. WBC count more than 2000, consider inflammatory arthritis. Less than 2000 is probably some sprain, strain, osteoarthritis, but more than 2000 start thinking about inflammatory stuff. More than 20,000, consider septic arthritis. And I, as a medical student and resident, I usually was fixated on that more than 50,000 figure. However, this article is really good. Does the patient have septic arthritis, published in JAMA, and it really goes over likelihood ratios and how your likelihood ratios change with different cutoffs of WBC in the synovium, and it is actually on the spectrum. So even the positive likelihood ratio for a 20K, white count is 3.3, I believe, and then it increases as you go higher to a 50, but it is still 3 times likely to have septic arthritis when you have a WBC count of 20, right? And then last pearl is reactive arthritis that happens 2 to 4 weeks after a GI or chlamydia infection. Remember, especially residents, gonococcal arthritis is separate. That falls under the bucket of septic arthritis, where you think about Staphylococcus aureus followed by gonorrhea, right? So those are your 2 main ones. And then in reactive arthritis, think GI and chlamydia. And then this is just to show you the lines all are blurry. And in summary, mechanisms of pain. We learned about 3 mechanisms of pain: neuropathic, neuroplastic, and neuroceptive. And then we have mechanical joint pain, which is minimal morning stiffness, better with rest, worse with activity. Example, osteoarthritis. Inflammatory joint pain, prolonged morning stiffness, swelling, worse with rest and improves with activity. If it is acute sudden, think septic arthritis, crystalline, reactive arthritis, or late onset rheumatoid arthritis. Insidious, think additive, polyarticular, small, symmetric, rheumatoid arthritis. And if it is mono or oligoarticular, mainly asymmetric, lower extremities, think more of psoriatic, reactive, IBD, and absolutely sarcoid can also be in this category. And that's it. I'm happy to take questions.
Thank you so much, Dr. Keywalker, for all of the pearls. We'll take some questions.
Thank you, Dr. Keywalker. That was excellent. Do the arthritides associated with psoriasis and reactive arthritis and IBD, are they different clinical entities in terms of their prognosis and treatment, or are they all rheumatologically assessed and treated the same way?
So that's a great question. Spondyloarthritis is distinct from rheumatoid arthritis. So rules of rheumatoid arthritis definitely don't apply to these. But I feel even though they are under the same umbrella of peripheral spondyloarthritis, they have their own prognostication and their own course. Each one can relapse and remit. So they are similar in that fashion. The IBD, for example, can ebb and flow with the IBD flares that you could get. So that makes it a little special. Psoriasis and psoriatic arthritis, not everyone with psoriasis gets psoriatic arthritis. So that's where the role of rheumatology and primary care, it could be osteoarthritis or gout rather than psoriatic arthritis. And then the reactive arthritis is definitely more, I think about it, at least 1/3 to 2/3 of the patients with reactive arthritis being more monophasic than psoriatic and IBD being more of a chronic thing. So hope that answers your question.
Yeah, because the online audience will.
Thanks, Dr. Kiwanuka. This is really great. Just curious, in some of these inflammatory arthropathies, is there any data to suggest that some of the newer biologic agents, the IL-1 inhibitors, the IL-6 inhibitors, will have a role in managing? They're obviously very expensive, but very effective in other domains. So I'm just curious about the inflammatory arthropathy.
Absolutely, absolutely. And we did go into management so much today, given the title of the presentation. But interleukin-6 especially, I'll start with interleukin-6 inhibitor, which is tocilizumab, or sarilumab, is definitely used a lot in rheumatology. It has great data for giant cell arteritis. It has upcoming data for polymyalgia rheumatica. We have been using toci in rheumatoid arthritis for many, many years now. So that has been great data, especially late onset rheumatoid arthritis. It is a great medication to use over there. Let's see, beyond that, really not much with the spondyloarthritis. So that's not the pathway, that's not the mechanism. So it doesn't inherently doesn't have usefulness over there. Talking about Still's disease, right? We have interleukin-1 and interleukin-6, which have shown to have quite good response, especially interleukin-1, anakinra. And in gout, let's not forget gout. It is driven by innate immunity, right? So interleukin-1 receptor inhibitor, which is anakinra, which is given to treat acute gout. So that's the current spectrum of utility of IL-1 and 6. Absolutely, and that's why it's only given in the hospitals. It's available only in the hospitals, not as an outpatient treatment.
Thanks so much. This was awesome. In primary care, I always feel a little guilty ordering all those labs, but I'm pleased to see I'm doing the right thing. The other thing I would order often is hand x-rays and foot x-rays and wrists and all of those joints, and you said nothing about that. So I was going to stop doing that unless you tell me otherwise.
So that's a great question. Imaging in rheumatology. So it depends on how long the patient has had the arthritis for. If it's newer onset, less than 2 years, x-rays won't show much. And that's why I shy from getting an x-ray in my rheumatoid arthritis or even psoriatic arthritis patients. I'll see nothing. Even in your gout patients, right? If it is the first or the second flare, we're not going to find much. But sometimes if I really don't know what's going on, which happens few times a week, and then I get x-rays, right? Because x-rays is just another tool to help you. If sometimes I'm looking for that chondrocalcinosis, the CPPD, I'm thinking, is it that? That helps me. Yeah, so there are different uses where x-rays could be used, but for the most part, don't think about that in your initial workup because you're not going to get much information in new onset conditions.
I'm excited that you're giving me courage to start treating my RA patients instead of just sending them off. I'm curious as to the patients that you've been seeing up in Vancouver or that are coming from other parts. Are like rural docs starting this and treating it until they need a biologic and then sending them to you? Unlike maybe more folks in our clinic who are like, you just need to see room because they're kind of accessible.
Right. So it could go both ways. It depends upon provider comfort. And I've seen it really, especially as you're right, especially in areas where there is lower access to rheumatology. People have started them on methotrexate. People have started them on hydroxychloroquine. I haven't seen anyone start them on a biologic, but definitely methotrexate and hydroxychloroquine are fair game, especially when the appointment is out 4 months or 6 months, because that window of opportunity is very important, right? That's the time when they will respond the most. And that's why I think there has been a push even at the ACR to start therapy on day one when you diagnose them, right? So don't lose that window of opportunity. I have had, because in Vancouver Clinic, we have many primary care practitioners in our system. So they sometimes just call the person on call. And I'm not on call today, so I can jinx, there's no problem, right? So they frequently call and ask, I have a patient. You can look at the EMR. I have some pictures for you. And so I'm training my PCPs to send me those pictures, just like they would do to dermatology. And they say, the RFCCP is positive and it really fits. Let's start treatment. And yes, I run through the methotrexate with them and they are comfortable starting treatments. And then I see them in 3 months. And that really gives me some information to work with after I see them on methotrexate for 3 months, which is superb. So please call your friendly rheumatologist. And it could be me. So you could just email me. That's fine. And I've told this to my residents. So that's okay.
Great. We have a question wondering if you can flesh out any more detail or pearls about joint physical exam. There are those patients where the OA joint seems a little warm. There are times when swollen joints are subtle. It's great when we get to read your exam. Any last physical exam pearls?
Sure. Do we have an hour? Okay. So let's keep it brief. So hands, right? It's tough. And that's the reason we have a 2-year fellowship in rheumatology. But let me try to condense it. Okay. So the hands. I look at both hands and thank God we have 2 hands, right? So we can always compare the PIPs in one hand to the PIPs in the other hand. And I agree, it's subtle, it's confusing. Look at those, what do you call these, ridges, or what would you say, these wrinkles or skin folds. Compare them, because if they are reduced in number and they look stretched as compared to the other hand, that means there is some swelling. They might not be warm. Remember, this is chronic subtle inflammation, and that's why your ESR and CRPs will also not detect it each time, right? So it's subtle. Looking at both joints will also help you. Just asking them to make a fist will look at these valleys and mountains, right? So that's pretty prominent. In people who have that obliterated, you will see it as one flat surface, right? So a quick call about MCPs, and then PIPs, you could ask them to make a claw. And if they have difficulty in making that claw, that means the PIPs have swelling. So that's very easy. Inspection, done. Okay, so even if you do that, and if you're not able to actually palpate the joints, which takes training, I have no idea what cardiology and pulmonary do these days. So it's very difficult to keep up as an internist, I'm very sure, from personal experience. But if you just remember, look at both hands, make a fist, make a claw, that will give you a lot of clue. Coming to the knee, because that's another place where we often struggle. The knee, what I do is, again, inspection. Okay, look for those bony deformities in OA versus any swelling. And remember, the swelling of the knee actually happens in the suprapatellar fossa, or the space, rather than below the knee. So that's a pearl. And then the shin should always be warmer than the knee. The knees are cool, the joints are cool, rheumatology is cool, remember that. And the shin, if the knee is warmer than the shin, or if the ankle is warmer than the shin, then you get that sense that this is probably inflammatory. The osteoarthritis, when it flares, it also can give you an effusion, and that's actually cool effusion. Okay, so textbook speaking, it's cool. although it's on a spectrum and it could be a lukewarm, but it's, of course, it's murky. But remember, it's usually cool. The inflammation from osteoarthritis, the modest inflammation from osteoarthritis that you get is cool. So that's how I would look. So again, inspect and palpate, range of motion. That's it. Don't do any fancy tests. Rheumatology, just keep it simple.
That's actually a great start and probably all that we can remember for today. So I think we're right at the top of the hour. Thank you so much, Dr. Key Walker.